My presentation is about using psychotropic medication to control acting out behaviors. Using medication to control behaviors has long been studied in the field of therapy and behavior analysis, determining if medication should be used, if therapy should be used, or if both should be used together has kind of been the dilemma. Medication is used to try and fix the determined problem, which is acting out or unpreferred behaviors that can be difficult and frustrating at times. But this can be looked at as a possible short-term solution and not a long-term solution to help the client learn. And determining if using medications only to manage behaviors is ethical in terms of the treatment of the client or what's easier for staff. Our ethical standards discuss what is in the best interest of the client. Bailey and Birch talk about how behavior analysts' assessment, recommendations, reports, and evaluative statements are based on information and techniques sufficient to prove appropriate substantiation for their findings. They go on to say the behavior analyst always has the responsibility to recommend scientifically supported most effective treatment procedures. Effective treatment procedures have been validated as having both been long-term and short-term benefits to the clients and society. And finally, they state that behavior analyst reviews and appraises the restrictiveness of the alternative interventions and always recommends the least restrictive procedures likely to be effective in dealing with a behavior problem. My stance on the topic is that using medication to control their behavior is unethical. I feel that it exerts control over the client. It puts the person giving the medication control over what's going on, and it does not present a learning opportunity for the clients to learn different coping skills and different acceptable behaviors. I understand that PRN medication is necessary in some instances, and the Illinois Department of Children and Family Services defined emergency medication as a psychotropic medication given to a child in accordance with the Consent to Minors to Medical Procedures Act. This is a medicine that needs to be used in emergency situations, such as trying to keep the client safe from harming themselves or harming others. My personal experience comes from working at a residential facility. The client, whom I'll refer to as Richard, was assaulted by a peer, which resulted in a DCFS investigation. And due to the investigation, he needed to be separated from his assaulter, whom he thought was his friend. Richard has autism and was lower functioning and didn't understand boundaries. Due to his assault and his move, he acted out with anger and aggression, which was not typical behavior that Richard displayed. And due to the increased aggression, Richard was prescribed psychotropic medication, but his therapy regimen and his group schedule regimen remained the same. It just felt that it wasn't right since he needed more intensive services, especially addressing the assault that he had, but those services were not provided. Psychotropic medication can be used as a physical restraint due to being a chemical restraint. A chemical restraint was defined as any chemical substance used to control or subdue a person's behavior. Drugs prescribed for the purpose of treatment of medical or psychiatric conditions are expressly excluded from this. Using medication to control behavior does not allow the client to learn from their behavior and their consequences for their choices, and they can't advocate for themselves, and it gives control to the person administering the medication. And I go back to what Bailey and Birch state, saying the behavior analyst has a responsibility to operate in the best interest of the client. So is the acting out behavior being controlled in the best interest of the client or for the best interest of the staff involved? It's kind of the ethical dilemma. The court case I found was Rothstein versus Hettenbach. In this case, the client was given PRN psychotropic medication due to his agitated but non-dangerous behavior. The client reported that he felt this was a violation of his physical body as well as his personal security. PRN medication is described as medication orders to administer a psychotropic medication for the emergency management of aggression, psychotic agitation, insomnia, and other troublesome symptoms without a physician assessment or specific approval according to parameters set by the licensed prescriber. So, this was an interesting case since he was determined to not be dangerous, but they still gave him the medication. And I think the best thing that comes to mind is how were behaviors that were acting out and dangerous managed 100 years ago since we didn't have all of the medications that we do now? What the research kind of shows is that foster care children are some of the most over-medicated, as Strawbridge stated that when medication takes preference over individual or family therapy, foster children can become over-medicated. She talked about an example of a child named Gabriel Myers. She said he was prescribed different antidepressants, which was his primary method of care. And although it is unclear if he was administered his prescriptions or if he was responsible for administering them himself, the burden of pain he suffered was left untreated, resulting in him committing suicide by hanging himself with a shower hose at the age of 7. One Florida review also revealed that 424 psychotropic medications were prescribed to a mere 268 children, with 34% of children on 2 psychotropic medications and 11% on 2 or more. So using medications to manage their behaviors is a large number. Another foster care child was described in the study, stating that he was prescribed medication for his hyperactivity and years later was taking double the medication, but was then given an antidepressant since a physician saw him and felt that he was so mellowed out he could barely react. Another study shown that fewer than half the children treated with antipsychotic medication received any kind of mental health assessment, psychotherapy, or psychiatric visits, meaning that they are given only medication and no types of therapy. Antipsychotic treatment with children has been accepted, although access to psychological services has been limited, and medications have been shown to help parents, teachers, and other child workers quiet and manage rather than treat children. Children with ADHD have also been prescribed lots of medication, although is unable to reliably return to the youth to a normal functioning or improve academic outcomes. The presumed justification for antipsychotic medications is for the neurochemical abnormalities, although the results are still not known. It can be concluded that the medication is simply based on their ability to suppress problem behaviors. Another population that has been given psychotropic medication are children with autism. Many children with autism have excess activity and impulsivity, which can be confused with ADHD and results in them being placed on medication. The purpose of medication is for preventing occurrences like self-injury or injury to others, and the goal is for children and youth to receive the medication they need and no more in order to maximize therapeutic benefit but minimize the potential adverse costs and consequences. But the benefits of therapy have been shown to have reductions in the use of psychotropic medications, in the levels of negative behaviors, and the use of seclusion and restraint. And they argue that within cognitive behavioral therapy setting, it is possible to safely and effectively reduce psychotropic medication rates to clinically appropriate minimum. There's a lack of consistency with kids in their diagnoses and medications. Studies have shown that children admitted to residential facilities have been diagnosed with multiple psychiatric disorders, which produce a large amount of medication. So determining which symptoms come from their environment, are side effects from medication, and which come from their actual psychiatric diagnosis make it difficult to know what diagnosis to use and what medication to prescribe. In determining an acceptable age of use is important since authors are now doing research on the use of psychotropic medications with young children. The authors state that there is little data on the effectiveness of the medication as well as its safety. The short and long-term effects of the exposure of the psychotropic medications on the developing brains of the preschoolers is largely unknown, and diagnosing psychiatric disorders in preschoolers can also be challenging due to validity and reliability concerns of the diagnoses, such as ADHD, mood disorders, and schizophrenia in young children, since there's not a lot of research on this. An example for acceptable age of medication is a girl named January, or they referred to her as Janny. I included the link at the bottom, but if you Google January and schizophrenia, lots of videos will pop up. She's been on the Oprah show and she's been on the Discovery Channel, but she was diagnosed with schizophrenia with a childhood onset. And they stated that she slept 4 hours a day as an infant, where typical infants sleep 19. And actually in that link they show her as a baby. They claim she was looking around and assumed they were visual hallucinations, but this resulted to her being diagnosed and psychiatric hospitalized numerous times and put on many psychotropic medications, and she's been having lots of difficulty, and now they're feeling that the same problems are arising from her little brother. So when is too young? So medication and therapy have benefits such as lowering medication dosages, decreased acting out behaviors, and decreased use of seclusion and restraints by staff. Having the client participate in talk therapies allows them to learn different ways to manage their emotions and behaviors and to cope with what's going on around them and their feelings. Psychotropic medications are necessary in some situations, such as chemical imbalances for diagnoses such as depression and bipolar. There are limitations in the research, such as further information for how acting out behaviors were addressed in history before the use of medications, the lack of data on the success of benefits of psychotropic medication in children with varying ages and mental health diagnoses, in analyzing the effects that it has on children, and focusing less on short-term versus long-term effects of the medications to help the children outside of the here and now, but focusing on long-term